Welcome everyone here in the room and then also online on Zoom. My name is Susan Eastland and I am on the programming team here at Cary Library. So tonight we are going to be hearing about the latest in diagnosing and treating Alzheimer's disease and other dementias. We are running this program in a hybrid format, so we thank everybody for your patience. We will be taking questions at the end of the program. At that time, if you're here in person, please raise your hand and I'll bring over a microphone. And if you're joining us from Zoom, please submit your questions to the Q&A and I will bring them up as they come at the end. This program is being recorded and will be posted to the library's YouTube channel. And so now I'd like to pass the mic to Heather Maloney, who is the Senior Director of Communications for the Alzheimer's Association of Massachusetts and New Hampshire. So Heather.
Good evening. Thank you for having all of us here this evening. We're excited to be here. As Susan mentioned, I'm the Communications Director at the Alzheimer's Association's Massachusetts, New Hampshire chapter, which is to say I am not a researcher. So I am going to be giving you a very high-level overview of the Alzheimer's Association and some of the work we do, as well as certainly the research that we fund, and give a little high-level overview of Alzheimer's and dementia before I turn it over to our two experts. So many people know the symbol of the Alzheimer's Association, but not a lot of people know what it actually represents. And as you can see here, that's a brain on the left and a beaker on the right, which really symbolizes both our commitment to helping families and people who are diagnosed with this disease, as well as really being involved in the science and funding the best possible research into Alzheimer's and all other dementia. It's important that we are not limited to Alzheimer's. The research that we fund, the educational programs that we put on, our support groups, all of our many resources are geared towards people living with Alzheimer's and other forms of dementia. So we are not just limited to Alzheimer's disease. Our mission is to lead the way to end Alzheimer's and all dementia by accelerating global research, as I mentioned. We're increasingly involved in driving risk reduction and early detection and maximizing quality care and support. And that includes our no-cost education programs, our support groups, and our care consultations, for example, that we offer to families. So I'm going to quickly cover sort of the landscape of Alzheimer's and dementia science and some highlights in early detection and diagnosis, and then talk a little bit about the latest in clinical trials and treatments. And our two doctors will certainly dive much further into that than I will, and then just a little bit about how you can get involved in the Alzheimer's Association. These are our latest facts and figures. We publish an annual report in March of every year that gives the updated sort of landscape of Alzheimer's and dementia in the US. Right now, there are more than 6 million Americans who are living with Alzheimer's. 1 in 3 seniors will die with Alzheimer's or another form of dementia. And Alzheimer's disease kills more than breast cancer and prostate cancer combined. We also know that between 2000, I think this is a really interesting statistic, if you look on the right-hand side, between 2000 and 2019, deaths from heart disease have decreased by 7.3%, while deaths from Alzheimer's disease have increased 145%. So clearly we have a lot of work still to do. And I really like this slide because I like this graphic. Many people use Alzheimer's and dementia interchangeably, and they're not actually equal. Dementia is the umbrella term that's used to describe a range of symptoms associated with cognitive impairment. And certainly many people are familiar with the most common symptoms, such as loss of memory. There can be some agitation, certainly aphasia or trouble speaking and communicating is another symptom. And then Alzheimer's is due to the biological changes in the brain. It's the actual disease that falls under that dementia umbrella, along with several other forms of dementia, including vascular dementia, Lewy body dementia, and frontotemporal dementia. Those are the 4 most common. Frontotemporal dementia has been in the news lately. That's what Bruce Willis was diagnosed with just a few months ago. That became public. And then certainly there are many cases where these commingle or overlap, and someone is diagnosed with more than one form of dementia. And we know that Alzheimer's disease is a continuum. It starts when people are asymptomatic. There are no cognitive issues present, but we know that biological changes in the brain, or we think biological changes in the brain, can start as much as 20 years before someone actually begins to exhibit symptoms. And then that will progress where symptoms become evident to MCI, which is mild cognitive impairment due to Alzheimer's disease, and then it follows a continuum that from there. And there are lots of different things that could impact a person's risk of cognitive decline or developing dementia. We have the non-modifiable risk factors like age and genetics. But then the more research that's being done, the more we're finding that there are modifiable risk factors that by altering them throughout the course of your life may actually impact your risk of developing dementia later in life. And that's everything from physical activity to sleep to diet. One of the things we like to say is we know that what's good for your heart is good for your brain. So a lot of the modifiable steps that we talk about for heart health, like eating a low-fat diet, getting regular exercise, not smoking, etc., are good for your brain health as well. We also know that social determinants of health in underserved communities may impact some or all of these risk factors as well. And it's important to note there's been a lot in the news about the amyloid treatments that have come out, but that as an organization, we're funding lots of different research into lots of different areas. So that's been the big, sort of the big in the news cycle lately, but we're looking at all different possibilities for what may help treat Alzheimer's, but also may help reduce risk in the long run as well. And as I'm sure many of you are aware, it is an exciting time in research. The organization, we are a global organization in that we fund research all over the world. We have currently over $310 million in active research funding in 48 countries, and that's funding over 950 projects on 6 continents. We are the largest nonprofit funder of Alzheimer's and dementia research in the world. And another important pillar of our organization is that we advocate. Our public policy teams in all 50 states and in Washington, D.C. advocate for research funding from the NIH at the national level, from the National Institutes of Health. And that funding has grown tremendously, which has really contributed to the great strides we've made in Alzheimer's research. In 2013, the NIH funded just a little over $500 million a year in Alzheimer's and dementia research, which is not much. And now this year we're up to almost $3.8 billion. And we continue to, we have advocates that travel to Washington to lobby Congress every year. And that goes a long way in advocating for these additional research dollars. And we know certainly now that more treatments are coming out and starting to hopefully become available, that early detection and diagnosis is more important than ever. It used to be that physicians didn't really have anything to tell anyone when they were diagnosed with Alzheimer's, and so there didn't seem to be a real need to have an early diagnosis. And one of the things we really try to educate families about is that an early diagnosis can have really important emotional, social, and medical benefits for the person who has received this diagnosis. It's important to certainly help to understand their symptoms and the continuum of the disease and how it will progress, to prevent complications and practical matters like making legal and financial decisions and accessing care services in your community. It also, with an early diagnosis, does give a person the possibility to potentially participate in a clinical trial, if that's of interest to them as well. And then certainly, most importantly, in this day and age, we're happy to say that it will allow people to be able to explore treatment options. So in the progress we're making towards risk reduction and more effective treatments, there we go. You can see that Alzheimer's disease was first described in 1906 by Aloysius Alzheimer. And since then, there was a huge leap, first of all, to the 1990s before there was really anything to even treat the symptoms of the disease. And for a long time, that's all we had. Pharmaceuticals that could help treat symptoms, but would not actually modify or slow the disease in any biological way. And that changed in 2021, and then again this year with the advent of two new therapies that both received FDA accelerated approval. Aduhelm and then Leqembi was just a few months ago. And both of those target the amyloid that builds up in the brain and that we think causes Alzheimer's disease. The two drugs help to clear some of that amyloid from the brain, those plaques from the brain, which has shown in clinical trials to slow the progression of the disease, which is important in terms of giving people more time when they're cognitively intact. And then there's another medication called Nanomap. I don't believe it's actually under FDA review, but will be shortly. And that one is showing even more promising results as well. So that one also targets the amyloid in the brain. And so it's an exciting time. We've never been able to say we're in the age of treatment before with this disease. And so just in the last 2 years, there's been tremendous progress with lots more in the pipeline. But even though these three medications all target the amyloid, the research that the association is funding is looking at all different aspects of Alzheimer's biology, and you can see some of them here. So we're not just putting all our eggs in that one basket, but all of these different areas combined with risk reduction, we think is going to ultimately give us a cohesive treatment plan ultimately for Alzheimer's disease. And it's estimated that up to 40% of dementia cases could be prevented or delayed by targeting those modifiable risk factors that I talked about. A healthy diet, certainly, and physical activity, and cognitive and social stimulation is also found to be incredibly important. We know that isolation among seniors and among people who have already been potentially diagnosed with Alzheimer's is incredibly detrimental to their health and to their progression of the disease. So that social stimulation is a big piece of the puzzle as well. And I wanted to just wrap up with giving you a few resources if you're interested in learning more about Alzheimer's research and the association's activity in the research realm. You can certainly go to our website. We have a great deal of information about all kinds of projects that we're funding. I should mention this earlier, we're funding about $24 million just in Massachusetts alone at Massachusetts-based institutions. So a lot of the money we raise comes right back into our own backyard to advance research here. We also have, if you're by any chance interested in learning more about clinical trials, they are both for healthy people and people who are living with Alzheimer's, and they're not all pharmaceutical trials. So if that piques your interest at all, you can go to our trial match site. And then of course, we also have our 24/7 helpline that's available for families, for caregivers, even someone who's just interested in learning more about Alzheimer's. It's a free helpline that's open 24/7 and always answered by a live person. And certainly I'm happy to answer any questions at the end, but I know our two experts are going to go into much more detail about some of the things I mentioned, but thank you very much.
I think I know some of you. I'm a local Lexington resident and really thrilled to be here. Library is my most favorite place in the world to be, regardless of the talk here today. And I just want to thank Alzheimer's Association, Anessa, Faith, and obviously Susan, who is helping us from the back. So thank you for all your help. My talk today is going to be mostly from the clinical standpoint and primary care standpoint. I do have a state role, which is not on this slide because I'm not speaking in my state role, speaking as mostly as a clinician and human being here rather than in my formal role. The talk is just to kind of quickly brainstorm with you in terms of how we as doctors think about diagnosis and how that applies to the dementia and Alzheimer's disease. What's the brief continuum of this world of cognition, and then how can we screen and think about assessment, and what do we need to do in future as well? What would be possible in near future are the three things which I'll talk about. And I'll go through this fairly rapidly and leave sufficient time for Mike to talk about, and then obviously want to make sure we have sufficient time for questions. So I'll go through this somewhat rapidly. Here is the kind of a typical trajectory. So we try to, people don't present with saying I have dementia or this kind of dementia. They are usually present with functional problems. And those typically encompasses either the memory problems, speech problems, or word finding difficulty problems, at times the financial and driving problems, and at times the severe problems of either behavioral neuropsychiatric problems as well as functional problems of just not able to get around. Most people don't have a great insight into their functions. I've rarely seen a person who comes to the clinic who has real dementia saying I have dementia and I want to get evaluated. It's usually their partner or caregiver or somebody else bringing them up, just to let you know. And in most cases when people show up saying I have a memory problem, they're usually more worried than anything else, and yeah, we need to do a careful evaluation, but rarely that turns out to be a real dementia problem. Then we try to, that's why again the second bucket in the green, we try to get supplemental information from the caregiver to validate some of the things. This is not to spy on people. This is literally to get the full picture of what's going on. And again, identifying the impact on function and daily activities is critical. We want to make sure we review the medications, because many medications are known to cause memory problems. Anticholinergic medications are the typically known, Benadryl and things like those. They can also impair your memory. And obviously all the sleep medications until recently can also impair your memory. We do a general exam in Alzheimer's disease. Typical exam is normal. So exam doesn't help you much, but we still try to rule out the other part which we saw, like Gulliver dementia and the frontotemporal dementia, which at times may have some physical signs. And then we try to assess the cognition formally. And there are many tests, which none of them are perfect, but you may have heard about some of them, which we'll talk about in a minute. And then we try to make sure we rule out any what we call reversible causes, which is the main reason for the blood test. I should have put folate right next to B12 as well, but we do routine blood count to make sure that anemia and other things are not contributing to your memory problems. Chemistry, make sure your thyroid is okay, your vitamin B12 and folate is okay. And then there are newer tests which are coming up, which are really interesting, and which you will hear more about hopefully in terms of amyloid, PET, and the MRI, which are going to probably change the field significantly. There's also a growing undercurrent of digital biomarkers, which is also growing at the same time, which may give us additional insights. The evidence on that is not ready for prime time, but I would definitely urge you to watch that, because that technological field is evolving quite rapidly as well. And then obviously ultimately we try to come with an assessment plan to mostly focus on function. How can we make sure both for the person who is in front of us, but also the caregiver is able to get through what we are dealing with. Typically I used to show the slide on the left, the normal aging, which sometimes people call it successful aging, where your memory does not go down. Your memory stays the same as when you were young. To AAMI is the age-associated memory decline in the second bucket, which is some decline, but it's kind of expected with age in some bucket. And then we get into this mild cognitive impairment, and then dementia over time. Nowadays, the things have been somewhat has evolved, and the previous slide, as you see here in the reference section, is probably from maybe 15 years ago now, or 16 years ago now. versus the recent understanding is this diagnosis of MCI is somewhat unstable. There are some people from MCI who do recover and don't turn out to be having dementia, and that's why you see some of this pathways going in a somewhat of a different direction, which is really interesting. Which is again still we don't understand the full spectrum of the cognition part. You saw this slide by Heather, so Heather, thank you. Again, one of my favorite slides as well. So I'll skip through this. You made my life easier, so I'm going to just quickly go through this. The main difference between MCI or mild cognitive impairment and dementia is function. Mild cognitive impairment does not impact function as significantly. It's versus dementia, the function is significantly impaired. If you like more complicated part, this is how the things typically evolve. Again, as just to summarize kind of my earlier slide of saying we get the history, do the diagnostic workup to rule out the reversible causes, do the cognitive and functional assessment, do structural imaging, and again, in future we'll have or we already have biomarkers which are evolving pretty fast, and then ultimately think about the treatment. Most of these slides I'm leaving you for as a reference as well, so in case you want to review it later on, you can too. The staging is complicated even for us. So just to show you the complexity of staging, different people, different groups use different staging, which makes life challenging. The FDA staging, which is how the drug gets evaluated, is probably at the bottom. National Institute of Aging has different kind of staging. I'm not going to go into details of this because that's not really the main focus here. But just to show it to you, there are different staging which are being evolved, and again, would love to get additional conversation on this. So I'm a geriatrician by training. I practiced geriatrics at Brigham for about 14-15 years before kind of downsizing my practice. And saw many of my patients for 10-15 years, which was a really good gift. And here is kind of my one slide summary on aging from my 15-20 years of work in aging. What happens with aging is you lose your reserve. Not universally, but for the most part. So you're fine at rest, but when you're stressed, your ability to compensate over time does go down in most systems. Second thing is the variability does go up. The cognitive trajectory and the variability as you age becomes even wider, what's normal and what's abnormal, which is really challenging. And it's also very personalized in some ways. And there are also, in general, higher risk of comorbidities. As you saw it for cardiovascular, we are doing way better than what we were doing before, but still, aging does bring multiple chronic conditions, at least at some point in time. The part which I would really like to do, which does not exist right now, is I would really like all of us to kind of assess our memory when you're like 40 or 50, 10 years before where I am right now, and then assess the memory test over time. Because it's my memory, which could be different than somebody else's in a good or bad way. So those things don't exist currently, or don't exist in a way they're easily available. There are things being developed on that stage, which will be super, super important. Because again, my baseline is my baseline. I spent my 26 years in India before I moved to US, which could be a different impact than and then obviously Indian ethnicity will bring unique aspect of this. I would not go through this, but as a geriatrician, we also try to assess function in different ways. And as you must have heard, primary care practices are getting busier and busier. We were just talking about this earlier, saying, you only have 10 to 15 minutes of a visit. Initially, when I was trained as a geriatrician, I was trained on the right-hand side, which are like ideal tests, which takes about 15 to 30 minutes to do each test. Over time, I moved into the left, where you have 1 minute test. And then if that screening test is positive, you do 5-minute test over time. But more and more I talk to my primary care colleagues, the 1-minute tests are the most common test. And again, I'll put 3 main domains in geriatrics. There are many others too: function, cognition, nutrition. And within cognition, dementia, depression, somebody might say delirium as well, are the common things. And you see the prevalence and other things. Again, giving you many different data points for reference. As you saw here in 1 minute for dementia, clock drawing is the most relevant test. And if you want to try it and test it out on your family members, you can certainly do that, which is asking them to draw a picture, basically draw a circle, and ask them to label all the numbers and set the time to 10 minutes past 11. Now, why is that so specific? Why is this test really good test? Because 1 unit on the clock is 5 minutes. That requires higher level of thinking. Also, 10 minutes past 11 requires differentiate between 10 and 11 and requires you to put your hands in a specific way, which, by the way, tricks a lot of people. You can see some different varieties, which I would not ask you to diagnose with this, except probably for this one. Any guesses on who this could be? Wonderful artist who was a fabulous, probably draw the best clock I could ever get in a nutshell. So there are people who will definitely get A+ on this. I would probably skip through some of this for the simplicity. You guys can review this at your leisure. The most commonly used tests are probably 2 tests, which again would love to get other people's input on. Is either this Montreal Cognitive Assessment Scale called MoCA, which is, again, I would not walk you through this, or second test, which I did not put in on the slide, is called St. Louis University, SLUM, SLUMS. The SLUM has become a really, really good favorite test because it tests your memory in 3 different ways. It asks you to test your memory with words, which is how typically we test it. We used to test memory on words with like immediate recall. I'll give you 3 words: apple, chair, sky, making it up, and you repeat it soon after that. There was no delayed recall, which is what SLUM has too as well. It also asks you to remember the numbers, and then it gives you a story and asks you to remember part of the story. So it tests your memory in 3 different ways, which is why SLUM has a better sensitivity and specificity, and it's still in open domain, so it doesn't require any copyright laws, versus MiniMental status exam, which we used to use for years, now is copyrighted. MoCA also requires some certification to make sure before you use it, versus SLUM is still in open domain, invented by a guy named John Morley, who's a geriatrician, by the way, for full disclosure. This is the MoCA part on the attention memory, which you in case you want to say this. And again, we'll skip through some of this slide purposefully. This is the MiniMental status exam, which many doctors used to use it. It's a good thing for monitoring, not good for diagnosis or screening, as I mentioned, for the most part. The physical function in general is also evolving in terms of how we assess it. I'm going to skip through this and we'll come back to this. And there are really good evolving science. If you're not been to Spalding, Cambridge, I would strongly urge you to go there, where they literally have a kind of a real life simulation lab where people's function is tested in a real life setting than artificial setting. You see the driving test being done here as well. And then more and more, this is the future. How many things we can sense now with the device, which I left it there purposefully not to distract myself. You can sense so much with some of these things, and it would be I would not be surprised if the good biomarkers or good digital markers starts catching up on this fairly quickly. It's about time, and this will also help along with some of the biomarkers being involved on this. Just to be a little bit more evidence-based, we did learn during the COVID the use of phone testing because people could not come to the offices safely. And frankly, this is a most recent review from May of last year, which basically say we still need to learn more about what that means. We don't know enough. In a nutshell, it's still something we need to figure it out. But we need to consider the pros and cons of this. What about the apps? There are many apps out there. I did summarize it for you, so in case you're interested, there's a cost summary and there's an article in case you want to review, which are some are just putting slums and other tools on the apps. Other ones are really good cognitive assessment tools. The country which has been really further ahead on this is Israel. Who was doing computerized testing with us in 2004 and 5. And those states are really coming to fruition. So I'm going to wrap it up in a few minutes, so make sure other speakers have enough time. But in summary, diagnosis of Alzheimer's disease and related dementia is rapidly evolving and will thankfully accelerate due to emerging treatment options. The reason why it was frustrating for people to diagnose, apart from preparing the families and making the decisions and giving patient real autonomy, which is the right reason, was at least in the kind of a traditional interventionalist mindset, there was not much to do about it. Now, those things are evolving, and it takes a while for us to fine-tune the intervention, but because the treatments are getting better and better and are rapidly evolving, it's going to be super exciting. Our journey, to be honest with you, was quite bumpy. I remember in 2004 or 5, I was asked by one of the investment institutions to look at 90 drug options for Alzheimer's disease. None of them proved to be beneficial. So it's a super challenging journey initially, but now it looks like we are almost there, or we are already there in some ways. I would again reinforce, and Lexington is super talented and super a resource in some ways. Think about how do we get the baseline function. I have many people who are CEOs and in a very affluent position saying, Jatin, what can I do? I know I am at high risk. There is no easy way to capture their memory beyond the paper tools which we have it currently, which is a real shame in some ways. So anyway, somehow if we can figure out, by the way, there was a UCSC doctor, Dr. Ashford, who has created one small test, but beyond that, I've not seen anything. And Heather and other people, if you have something which I don't know about, please correct me. And again, imperative to assess function. With that, I'm going to hand it off to Mike, and hopefully you will hear some amazing information. Thank you.
All right, great. It's nice to be here. Thanks, Faith, for having me. Okay, so I'll talk about advances in anti-amyloid therapeutics. So it's been a very eventful year, as has been alluded to several times in Alzheimer's treatment. Earlier this year, Nanomap, which we'll talk a lot about, probably more than you want to hear, was granted accelerated approval by the FDA. So it's still not widely available in everyday use yet. So it's approved if you have the right channels. There are ways to get it, but it's really not it's not offered by most hospitals yet, and there's reasons for that. But okay, so what is lecanemab? Well, it is a novel disease-modifying therapy, and I'll just I'll stop there for a moment, because isn't everything that you use as a treatment a disease-modifying therapy? And it's actually not. Most of the treatments we have now are actually targeting symptoms, right? So if you have a fever, you might use Tylenol to help your fever be a little lower, but it doesn't actually treat the underlying virus or something that you have that's causing your fever. It's the same thing here in Alzheimer's disease, that the things like Aricept or donepezil that you may have heard of, they actually are there primarily to treat symptoms. And what makes lecanemab so exciting is that it actually is designed to treat the underlying disease itself. It's actually designed to modify the underlying Alzheimer's disease itself. So exactly what is it? Well, it's an antibody. We all make antibodies, and it's designed in a lab, and it's highly specific, and it specifically binds what's called amyloid, and it takes it out. It takes amyloid out of one's body, and it's mostly in the brain in Alzheimer's disease. So as a reminder, Alzheimer's disease has two major abnormal proteins. One is amyloid, which we'll talk a lot about, and the other is a tau. And you have to have both of those in order to be diagnosed with Alzheimer's disease. But the idea is that perhaps amyloid is the really important one. A tau perhaps comes along later and can cause some damage, but amyloid is the first and the earliest and perhaps most toxic of these two proteins. That idea is called the amyloid hypothesis. And that's sort of why there's been so much early focus. It doesn't seem early, but there's been a lot of focus on amyloid as a target as opposed to tau. So what lecanemab does, again, is it binds these specific species of amyloid. They're called oligomers and protofibrils. So we think of amyloid plaques, they're all these things in a huge clump, but the protofibrils are the little elements that are kind of floating around. And perhaps it's those protofibrils that are actually more toxic than the plaques. So it binds those small species and it takes it out. Importantly, it's administered IV, which is something that we'll talk more about. On the right here is a amyloid scan. We actually have ways of measuring amyloid in the brain via these amyloid scans. You can see here if you have received something like lecanemab, your amyloid levels are lower. And we'll come back to this exact study actually later on. Okay, so let's talk about what we know about lecanemab. What was the data? What was the actual trial that was done that allowed us to say we think this medicine is helpful? So this was a phase 3 trial. It's called Clarity AD, and it is a large double-blind placebo-controlled study. So almost 1,800 patients across 245 sites were enrolled, and again, half of them received the placebo and half of them received lecanemab. Importantly, this was in people who had MCI, that kind of early stage of Alzheimer's, or the very mildest stages of dementia. This didn't include folks that had moderate or late stages of dementia. They had to have a certain score on their cognitive testing. So we heard about the MMSC, the MiniMental status exam. You had to have a score of 21. And my sense of MMSC, having done this a while now, is anything really less than a 27 is kind of abnormal. And if you're less than 20, you're really going to notice it in your everyday life. So these are folks that have some symptoms, and we see evidence of that on the MMSC. Importantly, they have to have a memory loss. And you might think, oh, isn't that what the MMSC measures? The MMSC you measures a lot of things, including memory loss as part of it. And you actually have to have amnestic Alzheimer's disease in order to have been enrolled in this trial. You had to have a certain amount of functional decline. That's actually, really, we can come back to that in a moment. And then, of course, all the things that we've spoken about so far, that wasn't enough to get you into this trial. You also had to have an amyloid scan. So you actually had to have a biological marker of Alzheimer's disease. So you had to have all those other things, and you had to have amyloid in the brain. Importantly, they excluded people who had bleeding in the brain, which again, I'll come back to why. But they allowed folks who were on anticoagulants, so things like Coumadin, Eliquis, Xarelto. Folks who were on those also were in this trial. And they were followed for 18 months. So let's see what the data shows. So, what lecanemab does, what you can see here is on the right here, you've got the placebo versus folks who received lecanemab. And this is actually, how much amyloid there was in the brain as measured on a PET scan. And you can see that, over time, 3 months, 6 months, 12 months, 18 months, the levels of amyloid were essentially becoming lower, which is exactly what it's supposed to do. So this study showed that lecanemab has a biological effect. It takes out amyloid. The main endpoint is something called the primary endpoint, which is what the trialists say. This is what we're going to use to say whether or not this actually worked or it didn't. And that was what's called the CDR, or the Clinical Dementia Ratings Scale. And this is a semi-structured interview with the patient and the study partner, and it really measures functions in 6 different domains. So things like your memory function, your judgment, even things like everyday hobbies. And they score each of those 6 domains from a score of 0, which is normal, to 6, which would be severely impaired. And in MCI, the average for these domains would be about 0.5. So the scores are very low. They're not very impaired in MCI. Whereas if they have severe dementia, it would be 18. So, and they add up all these 6 different scores, and so the maximum score on the CDR would be 18, and the lowest score would be 0. And to note that at baseline, the folks in the study had a CDR of 3.3. So they were roughly scoring 0.5s, or these very low scores in each of these functional domains. And what you can see is that over time, as you measure one CDR over 18 months, you see those curves start to split, right? So those who are on lecanemab had less reduction in their, had less increase in their CDR, which implies that they had a slowing of their scores. And again, these curves are split kind of right away, and they actually are getting wider as they've been on this medicine over time. So this was a highly significant score, and it reduced the overall change in the CDR by 0.45 at 18 months. So it met its primary endpoint. They also looked at other measures. Does it actually improve or does it slow the decline in one's cognitive functioning? So here they used a test called the ADAS-Cog, which is a set of pencil and paper tests that measure performance across different domains. It's a 14-item test, and you can see scores here plotted over time, and it shows that, as you can see, at 18 months, lecanemab actually slowed the rate of one's memory loss, or at least one's cognitive decline, as measured on the ADAS-Cog. Again, you're relative to placebo. And then, interestingly, it also has an impact on other, biological markers of Alzheimer's disease. So on the bottom right, on the bottom left, that's amyloid. That's another marker, but this is in the spinal fluid now. So if you measure one's spinal fluid, it actually shows that the amyloid is, well, it's a confusing graph, but in the spinal fluid, a high amyloid level is actually a good thing. So you can see the amyloid levels are rising, which means that the medicine is actually working. Again, relative to controls. Interestingly, the tau levels were actually also lower when people were on lecanemab relative to placebo. So even though it targets amyloid, the tau levels, that other medicine, the other protein that's abnormal in Alzheimer's, was also affected. They also looked at overall markers of a degenerative disease, what's called a neurogranin, and that was actually also lower in lecanemab. So what does this show? What's the summary overall? Well, one, it removes amyloid effectively. It slows the rate of decline in function and cognition, and two, it has a positive effect on other markers of disease. So, of course, the open questions here, are these changes clinically significant? We know that statistically they are, but what does it mean to have a change of 0.45 on one CDR? And then the efficacy curves are widening at 18 months. The key here is, will those curves continue to split, or will they start to go in parallel? Because if they continue to split, then the effects that you may be relatively small at this time point over 5, 6, 10 years, which again, Alzheimer's is a long disease. Those curves, those might be, they might have a much, a larger and lasting effect. That's the hope. We don't know the answer to that yet. So of course, that's the upside. This drug seems to work. Now, what are the downsides? Well, it's common to have an infusion reaction that happens about 25% of the time. Usually that's manageable. That's not a concern that necessarily would have someone to have them be off this drug. Again, sometimes it can be severe, but that's not something that is unmanageable. Really importantly here is in the study itself, there was actually no difference in dying. Folks who are on the drug or who weren't, they died at the same rate, which is less than 1%. And again, these are older individuals. Sometimes death happens, and it's not necessarily a side effect of the drug. Okay, here's the one that you need to really know about, because you'll hear about this. This is called ARIA, or amyloid-related imaging abnormalities. And it's been criticized because the term ARIA sounds so lovely, but in actuality, you don't necessarily want to have ARIA. It's not so lovely. So, what ARIA is when you have these antibodies and they're binding amyloid and they're pulling it out across vessels, it causes those vessels to become a little leaky, right? There's little holes in those vessels, and it causes some fluid to shift with it. That's called edema or swelling, so that's called ARIA-E. And if those holes are large enough, you can get a little bit of bleeding with it, and that's called ARIA-H, or hemorrhage. And you can see that evidence up here. So these little white kind of lines here, that's an example of ARIA-E. There's a little bit of swelling here. And these little microbleeds, these tiny little microbleeds, these little dark areas in this larger area here, this is ARIA-H. So these are abnormalities that you see on MRI. So with lecanemab, about 12% of folks had ARIA-E, relative to about a 2% on placebo. Again, most of these didn't have any symptoms, only about 3%, and of that, most of those symptoms weren't serious. ARIA-H was higher, about 17%, but again, the rates of symptomatic ARIA-H, again, those little microbleeds, was very, very low, less than 1%. And then about 21% of folks had either ARIA-H or ARIA-E. So some form of ARIA happens regularly. It happens about 1 in 5. And importantly, there's a gene that's called ApoE, and there's a risk allele called ApoE4. And if you have 2 copies of ApoE4, one from your dad and one from your mom, that gives you a much higher risk of having ARIA, when you're on lecanemab. And of note, while they allowed folks who were on anticoagulants, a higher rate of them had what's called a macrohemorrhage, a larger bleed, not those little microbleeds, but a larger, over 1 centimeter hemorrhage. And that's obviously something that would be a more serious adverse event. It happened in about 2.5% of folks who are on anticoagulants. After the study's done, they do what's called an open label extension, where they allow everyone to be on lecanemab. So there's about half of folks who were at least offered this new medicine, and in that setting, there were actually 3 deaths. One of the people was on anticoagulation. One was given a clot-busting medicine called TPA for stroke, and they had a large hemorrhage and died. And then one patient who was not anticoagulated.
How many people were in that study that had 3 deaths?
Everyone was offered a lecanemab, but presumably half of the group that was offered wasn't already on it. So that would be around 900. I don't know what the retention rate was. So if 900 were offered it, how many actually ended up taking it? That's not 100%. So I don't know that what that denominator is, but I imagine it's probably in multiple hundreds. Yep. And we don't know the rate of dying, but this is obviously something that is important, right? So let's talk about, let's summarize, what the safety is here. So the most common side effect is an infusion reaction. ARIA of any kind happens in about 20%, usually asymptomatic, and it's most common in people with ApoE4 alleles. There's a higher risk of macrohemorrhages in folks on anticoagulation, and there was no difference in mortality during the actual study, but during the open label extension, there were 3 additional deaths. Again, unclear if they actually relate to the drug or not. So the open questions here is anticoagulation safe? And then a larger question here is, do the relatively modest benefits that we already talked about at 18 months outweigh the these risks here that we've also talked about. So I will just mention, this is a busy slide, we don't have to go over all of it, but there's another medicine that also is an anti-amyloid antibody that shows promise against Alzheimer's disease. And it was actually a phase 2 that was already written up in the New England Journal, and it showed that indeed they actually met its outcome. They have this test called the IARDS score, and that you can see here on the lower right that actually shows there was a that being on medicine slowed the rate of decline. It also showed very successful removal of amyloid from the brain. And then they just recently finished up a phase 3, a much larger trial. We don't have all the data on this yet. It was just, they sort of just released the kind of a top line results. But what it shows is a similar, if not a better benefit on these cognitive and functional outcomes for Nanomap relative to placebo. Interestingly, the rates of ARIA were a little higher in this drug, and there were 2, possibly 3 deaths that were attributed to the drug itself. And they had an interesting design where once you got to become amyloid negative on your amyloid scans, they actually stopped administering the actual drug. Again, presumably because it to lower the risk of ARIA, right? If you don't need to have a drug, why take the risk of being on it? So, why is this not here now, and what are the barriers to access? One is it's really expensive. Out of pocket, Eisai is offering this at $26,000 a year, and right now, Medicare isn't covering it in a widespread manner. It's actually restricting coverage to those who are enrolled in a study. There's a thought that if the FDA changes its approval from accelerated to full, which we're going to know that actually in a few weeks, perhaps in a couple of months, then perhaps Medicare would follow suit and offer coverage, and then after that, perhaps the private insurers would also. But that's as of now, it's not really covered. I think there are also really labor-intensive procedures for patients, right? You have to get an AD biomarker, which means right now it means a spinal tap. We don't actually have amyloid PET scans in the clinic because they aren't covered by most insurance plans. So everyone who is possibly eligible for this medicine would need to have a spinal tap as of now. It's IV infusions every 2 weeks, and how long you'll need to be on it is unclear, right? They studied it at 18 months, but there's no evidence to say that stopping is safe, right? We still know that, and we don't really know what happens after that. You have to get multiple MRIs over the first year to monitor for ARIA, and then of course you have to have expertise in your area. So it'll likely folks at academic centers will have access first, but maybe not across the whole country. So lots of the barriers on the patient side, and this has nothing of the institutional barriers, right? There are really quite a limited number of doctors and other providers with enough expertise in dementia where they feel comfortable and ready to use these medicines. And even general neurologists I've spoke with, they say, we're going to make sure we refer these patients to you because we don't know how to do this yet, and that's very reasonable. Yet there's not enough of us to sort of do this. Of course, there's a whole new radiological entity called ARIA, right? And the radiologists have to learn to do this and learn to recognize ARIA and to not undercall it or overcall it. Eligibility is intense, right? You have to get an MRI, a spinal tap. You have to be assessed cognitively. You have to have ApoE gene testing likely. that's a large data set to gather on every single patient that comes into a hospital. That takes time and resources that we may not be equipped for. And then, of course, there's complex counseling about benefits in risks, which needs to be done well, and it takes time. And then, of course, monitoring therapies is also resource intensive. MRIs or ARIA, and of course, if there is something on the scan, then you have to be able to respond urgently to the ARIA. So I think I just wanted to share some of the efforts that we're doing at Mass General Brigham, which is exciting. We're developing a kind of multi-institutional team of specialists that are really working to prepare and get ready with our clinical infrastructure. We're developing guidelines for appropriate use and safety monitoring. And the exciting part is we're actually developing, a novel care model so we can really efficiently meet everyone's needs here. It's a different kind of a model, and it's one of the more exciting elements of what we're working on. And then, of course, the Alzheimer's Association has been helpful, I believe, in setting this up, called AlzNet, which is our kind of a registry where we can learn about how this what are the real life impacts scientifically and clinically of these anti-amyloid therapies. So we're going to be a part of that again once that's launched. I think there are some exciting areas where this might be headed. I think one would be the IV element. If that they're already looking at subcutaneous formulations. If you could just have an injection, that might be much easier than having to come into the hospital every 2 weeks. There are other anti-amyloid therapies, as we've already mentioned. And then I think one of the really exciting areas is a combination of amyloid and tau, right? So we've focused so hard on the amyloid, but there's a whole other protein, right, that isn't being targeted yet. So the idea of, using a combination of anti-amyloid, anti-tau therapy, perhaps you could have a benefit, from both of those. And then I think probably the most exciting area is the idea behind Alzheimer prevention study. So this is folks who, as was mentioned earlier, Alzheimer's disease is in the brain for years and years and years, well before the onset of symptoms. But we have tools to measure those Alzheimer changes early on. So you can get an amyloid scan or a spinal tap or some other way of measuring your Alzheimer's disease, markers. And if you're at risk, if you have those markers, perhaps you could benefit from getting an early infusion of something like lecanemab. And the idea is that you could actually prevent the onset of symptoms in the first place. There's a study that is called the AHEAD 3-4-5 study. It's looking at this exact question using lecanemab, and again in cognitively normal individuals with AD, markers. And we are doing a lot of this work at the Brigham. So if there's interest in anyone here in enrolling or learning more, I've given our kind of a leader here her email out, with her approval. So please, for sure, reach out if this is of interest. So just a few final thoughts. I think it feels like there's this sudden breakthrough, but really it's actually been very, very incremental over many years and many decades, over the collective efforts of many individuals. Of course, researchers, doctors, philanthropic organizations, public investments, but probably as much as anyone, patients and research participants and their families. This is definitely a start. It's a good start, but there's much more work to do. And as we move therapies from the bench to the clinic, the need for ongoing philanthropic support, not only for research, but also for clinical care efforts has never been, more urgent. So thank you.
Thank you very much, Dr. Erkkinen, Dr. Dave, and Heather. This has been a wonderful presentation, certainly one of the most exciting and optimistic presentations on Alzheimer's research that I've been to in many years of going to these kinds of presentations. My name is Faith Parker, and I am the co-chair of Lexington Goes Purple, and this lecture was organized with Cary Library by Lexington Goes Purple. We are Lexington's annual awareness and fundraiser benefiting the Alzheimer's Association. We have a number of activities that take place in May and June under the auspices of the Longest Day program of the Alzheimer's Association. All of our activities benefit the Alzheimer's Association, so if you participate and make a donation, all donations go straight to the Alzheimer's Association, which, as you have heard, funds Alzheimer's research and funds critical care and support services for Alzheimer's patients and families. You may have seen around Lexington, many people have Lexington Goes Purple lawn signs in their yards. You can order one from us and we will bring it to your house and put it up in your front yard and take it away sometime in late June. And all you have to do is agree to have it. We are planting in partnership with the Lexington Field and Garden Club. We are planting purple flowers in flower beds around Lexington Center, and you can support that effort by making a donation. And when you make your donation, you can identify the name of someone you would like to honor, and we will be honoring them by placing their name, painting their name on a purple brick, which we will then use as part of the border of those flower gardens. So there'll be a lovely way to honor someone you love who has been affected by dementia, can be a patient, can be a caregiver, and to support the association. And on June 10th, we will be having our signature Purple Puppy Promenade. We ask dog owners to gather in Lexington Center around 9:30 in front of the depot, dress your dog in purple, and we will parade the dogs around Lexington Center to Hastings Park. We will give out awards for the best dressed dog, best behaved dogs, best dog tricks. We have an agility playing field where the dogs can play in Hastings Park. It's a very fun event, and if you have a dog or you know a dog and would like to take part, we would love to see you. And all day on June 10th, we will have 3 lemonade stands up and running around Lexington Center, so stop by, have a cup of our delicious lemonade, and donate to support the Alzheimer's Association. How can you help? You can go online to bit.ly/LexPurple and learn more about our efforts. We have posters, we have them up in the back of the room, and if you have a place of business here in Lexington, display a poster, display a lawn sign in your front yard if you're a resident, attend our activities, and follow us on Facebook. So thank you very much for coming this evening, and now I'd like to open up the floor for questions. Once again, if you have a question in the room, please raise your hand, and Susan, I'm sure, has gotten several from folks attending online.
I'm just gonna switch the camera over for people at home. Lights a little bit. Yeah. There we go. I'm gonna unplug this. Perfect. And you can just turn your mics on.
Also, pull the mic out if anybody has any questions or comments.
All right, anyone in the room have questions?
Could you explain what you meant by aria? It clearly is something bad, but I failed to make the connection. What causes it? What you're worried about?
Yeah, great. So so ARIA is an acronym, stands for amyloid-related imaging.
Sorry, can you just use the mic?
Yep.
Thank you so much.
So, check, all right, we got that. Yeah, so ARIA is an acronym, A-R-I-A, and it stands for amyloid-related imaging abnormality. So it's defined by what you see on an MRI. That's what the acronym stands for. But of course, it reflects an underlying biological change. So what is that change and how does it get there? Anti-amyloid therapies, they bind amyloid, and when the amyloid is pulled across blood vessels, on its way out of one's brain, it makes the walls of those vessels leaky. And when it leaks, you get some swelling. And when it leaks, you get some hemorrhages. And that's what you're seeing on the MRI. So it's because of the amyloid antibody itself taking out the amyloid, that's what causes the ARIA. It's really those microhemorrhages, those little bleeds, and the swelling, right? Usually it's asymptomatic, and when it is symptomatic, it's not usually serious, but of course, even a very rare event like that is something that we want to pay attention to.
Anyone else in the room?
All right. So considering that amyloid, the protein can be binded, is there a way to like stop the gene from being like how do I say it? Sorry. Like is there a way to like use RNAi in like therapeutics to stop the gene? Because the reason why I ask is because I work with recently I work as a research assistant at my college as a working with C. elegans, where we get to see RNAi, and so yeah. So I was wondering if therapeutics could use RNAi to like stop the gene from being expressed.
Great question. I think, so one of the more exciting, so I don't know specifically about RNAi. I know that so one of the interesting anti-tau therapies, again, that's the other, protein that we haven't talked much about, but it's very important. One of the exciting areas is an antisense oligonucleotide against the tau. So basically it prevents one's cells from generating tau, is how that works, and lowers the expression of tau in the body. And there's some early data that the antisense molecule is effective at lowering tau. And we don't yet know, that's what it's being looked at next, is whether or not that will actually have an effect on one's a memory or function. But it's an exciting area, is these sort of anti-tau ASOs. Right, yep. Yeah.
I think just really to add on this, I think one of the challenges, and in my bias view, probably the mistake looking back until recently what we made, we got stuck on amyloid hypothesis very severely and did not look beyond that in some ways, which I'm glad we are looking into it right now, because we put most of our eggs into amyloid hypothesis bucket and did not look broader. So I think to your point, we will need to look at the other targets, and I'm glad amyloid hypothesis is turning optimistic, which seems to be really there, but we will need to broaden our thinking. And frankly, many of those amyloid hypothesis people are in Boston, so we were biased towards our own experts and people here, which we need to challenge ourselves on.
Did you mention that in one of the studies you are looking at or you're monitoring people's daily activity? So are you trying to monitor? So instead of using those PET scan or other clinical method, you try to evaluate their cognitive status based on their daily activity? Could you elaborate on that? What kind of activity is included in the evaluation?
Right, good question. So just a few things. So in the studies that we talked about, they don't get daily monitoring. They get periodic, cognitive testing, functional scales, et cetera. But it's not daily. And those are the studies that we looked at now. There are some exciting areas that were mentioned, where things like wearing a smartwatch or how you use your iPhone, whether or not that may in some way be an early indicator of a change in your brain function, right? But that's experimental, but that's not necessarily what is being used in these larger trials at this time. They're just being studied kind of as an independent avenue at this point. Those are called, and that's called digital biomarkers, right? There was some sort of signature about the way you use your iPhone that can say, if you use it in this certain way, your risk of having Alzheimer's is much higher than if you don't. That would be interesting, and that would be a way of perhaps ensuring those who are at high risk, they get the better workup that they really need. More to add to that.
Well, I think Dr. Erkkinen's colleagues at UCSF, Jeffrey Cummings' paper on this one is the really good one, which is the part which I showed, which is basically how do you come up to the digital biomarkers and start passively, not actively, monitoring the activities without doing any additional assessment. There is a researcher at MIT who does have this kind of device which basically stays in your house like a Wi-Fi, but monitors all of your activities. It's already there. We just need to make sure we can evaluate this further. By the way, this is not only for dementia; it's for many other things as well. Right? The measuring the function and activities passively and intervening to basically improve function is going to be super important going forward. And again, I think technology is there. We just need to make sure how we can apply that to the outcomes of clinical trials, which we are not traditionally used to. So it's a brilliant question, which I think, and again, Jeff Cummings' work shows future is already here. We just need to start getting used to it and applying it, which we have been somewhat stubborn about.
So we do have a question from Zoom. Why is the lecanemab so expensive?
I don't know. I don't know. I think they've probably invested a lot of money and resources in not only lecanemab but other drugs that haven't fared so well, and they're trying to recoup their losses like any company would and make a profit. So I think some of that is healthy and good. Some of that probably, you always worry, is it priced too much where it's kind of make it so people can't afford it? So these are questions, but how they calculate all that, I don't know. Right.
And then another one, has it actually been established that removing amyloid and TAU or tau could reverse the disease?
No. What you can do, if you remove amyloid, you can have your amyloid scan look as though there's no amyloid in it. And that correlates with the slowing of decline in your memory and your function. But importantly, it's a slowing of decline. It's not a complete flattening of the curve. It's definitely not an improvement in one's memory. It's a slowing of decline. So as of this point, there's definitely not evidence that we have arrested or you got rid of Alzheimer's disease with any of these drugs by any stretch of the imagination.
Yes, I have heard in other talks I've been to that one breakthrough that we hope is coming down the pike shortly is the ability to diagnose amyloid or tau buildup through a blood test. Can you talk about that?
Yeah, it's a game changer. I mean, right now, one of the big barriers is spinal taps. Even in our clinic right now, we are ramping up our spinal. People are already interested in this and wanting to get spinal taps and know what they have for a biomarker. That our spinal tap wait list is already getting longer, and imagine if these drugs are actually available, that will get even larger yet. So the availability of spinal taps and amyloid scans is a major, a bottleneck to getting these drugs into folks that need them, that would benefit from them. So I think a blood test is really important, and I think we are on the cusp of it. There's actually some good data saying that they are nearly equivalent, but they just haven't been validated enough yet to where they're in routine use yet. So I think my hope is that in a year or two, we'll be using a blood test instead of a spinal tap. I think that's likely to happen.
One kind of tangential comment on this. I think as we are planning the capacity for this, we will need to really think about health equity. Eastern Massachusetts, we are very lucky to have amazing centers like Mass General Brigham and so on, NDI and Leahy, and What about rural areas? What about Western Mass? What about people who don't speak or have limited English proficiency and so on? So again, we need to start thinking more and more about it. I think the good part about the Nanomap trial was the population in study was quite diverse compared to previous studies. So I think we're making good progress on this, but as far as the implementation is concerned, we also need to think through the same challenges, which I would strongly urge all of us to remind ourselves, because at times we don't think about these issues proactively. And those tools, some of those tools are not available in certain languages.
I think we'll wrap up with a last question from Zoom. This is a general question for the Alzheimer's Association. If the adult children resist obtaining a concrete diagnosis for the parent because they do not want to medicate, are there DIY type tasks to do with the parent to best manage the decline?
So, do you want me to?
I can. So there is a tool called 88, which is by the same group at St. Louis University, which is probably something which you'll be able to Google it up, and it's a tool which family members can fill out based on their judgment. That's one thing, and then ultimately, obviously, with the person's permission, sharing that with the physician would be a good thing to do. I think the other way to potentially get over the resistance is to say, when somebody has the capacity, we want to understand what the preferences are. So that the longer you wait, the less autonomy you give it to the person to diagnose it. So I think there's a human aspect to just diagnosing this, apart from the therapeutics and great things which you are describing, which are all wonderful, but even simple decision making. Earlier you diagnose, the better you empower the human being, rather than, again, other people control. I hope that's indirect response, but.
And I just wanted to add to that, our 24/7 helpline that I talked about is staffed by trained clinicians and social workers. So this is the perfect type of question to call our 24/7 helpline to get some advice, maybe on how to deal with that resistance, and have someone who can advise you on how to come up with ways to manage that situation as well.
That's great.
All right, so we're gonna wrap it up on Zoom because the library is closing soon. So thank you so much, everyone here in person, everyone online, for tuning in. Thank you so much to our 3 speakers tonight. And again, we have recorded this talk, so it will be available on our YouTube channel within a week. So thank you so much. I'm gonna sign off on Zoom, and good night.